Silva, and I'm going to tell you about Desipramine. Desipramine, a tricyclic agent, first generation antidepressant that is a serotonin norepinephrine reuptake inhibitor. However, it is negligible in terms of its serotonergic reuptake inhibition. Like nortriptyline, it is really mostly an NRI. So much so that you can combine it safely with monoamine oxidase inhibitors, and you don't have to worry about serotonin syndrome. It has a tiny bit of serotonin reuptake inhibition, but it's not something that you worry about. It's the active metabolite of imipramine, which ironically not only has a whole lot more serotonergic activity, serotonin reuptake blocking affinity than desipramine, but along with clomipramine is one of the most serotonergic tricyclic agents. So you would really not ever want to combine imipramine with the monoamine oxidase inhibitors. And I've got other videos on some of this. If some of this is not making sense, there is a video that I talk about the tricyclics as a class. I go into the mechanism of action and the side effects, and then I do a nutshell on all of the tricyclic agents. So if you're interested in that, please check it out. But basically in blocking, I'm not going to call desipramine a serotonin norepinephrine reuptake inhibitor, although technically it does have serotonin reuptake blockade activity. I'm going to really refer to it as an NRI because that's really what it is. And so in blocking the reuptake of norepinephrine, noradrenaline, which is a neurotransmitter, one of the monoamine neurotransmitters in the brain, it increases the concentration of that chemical at the synapse, the gap between neurons, where the neurons are communicating and releasing those neurotransmitters is what causes the action. And so we want to increase it in depressive states, not so much in anxiety states. That could actually exacerbate anxiety. Serotonin is what you want for anxiety. But for depression, where you're down, you feel low, and you're unmotivated, and also difficulties concentrating and cognitive symptoms, because in the prefrontal cortex, blocking the reuptake of norepinephrine also increases dopamine, the third monoamine neurotransmitter, which is what you increase when you take a stimulant when you treat ADD. And so also to increase the sex drive and to increase motivation and initiative, you get that, at least in that area of the brain, without the potential for euphoria and therefore abusing the medication, because you only get dopamine increased in that part of the brain. And it's very similar to Strattera. So when I think of desipramine and nortriptyline, I think of Strattera more than Effexor or Cymbalta. Effexor and Cymbalta, venlafaxine and duloxetine being the second generation of SNRIs that differ from the tricyclics in that they're much cleaner drugs. They're much more selective drugs. They came after the SSRIs, the selective serotonin reuptake inhibitors, but they are not antihistamines. They are not significantly anticholinergic, blocking muscarinic acetylcholine receptors, and they don't block presynaptic noradrenergic receptors, alpha receptors, so they don't cause postural hypotension. They're cleaner and they're safer. Effexor and Cymbalta have a lot fewer side effects than the tricyclics, and they are relatively safe in overdose. Cymbalta is thought to be potentially fatal in overdose, but the tricyclics are very dangerous when you take the whole bottle. So desipramine is approved by the FDA for the treatment of depression. It's used off-label, however, along with all the other tricyclic agents to treat insomnia because it tends to be sedating. It's good for chronic pain, especially neuropathic pain. The blockade of norepinephrine at the level of the spinal cord is the mechanism of action that's responsible for why duloxetine and venlafaxine and really any norepinephrine reuptake inhibitor would reduce the perception of pain. But it's also good to prevent migraine headaches. It's used a lot for treatment-resistant depression. There's some evidence to show that the tricyclics and SNRIs in general, I say SNRI there, but that this class of agents just in general might be better than the SSRIs for the treatment of depression. However, for anxiety, I would not count on desipramine or nortriptyline. They're negligibly serotonergic, and that's what you really need to reduce anxiety. This medication would also theoretically, this is all off-label, there's no FDA approval, there have been no double-blind placebo-controlled trials that establish there's a statistically significant probability that these medications would in fact help these conditions, but there's a lot of anecdotal evidence and clinicians do use them. And so on a case-by-case basis, certainly they do work sometimes. For the treatment of smoking cessation, like bupropion, Wellbutrin, which was actually approved under the trade name Zyban by the FDA. That actually got the FDA indication, as well as we think maybe cocaine. But there's no medication that's ever gotten the FDA indication for cocaine dependency. I always say there's no silver bullet, and there's so many things that go into being a cocaine addict.
You got to do a lot more than take a pill to get yourself into remission from that particular disease and stay in remission.
Like Pamelor, nortriptyline, desipramine has a therapeutic window. Certainly it's intuitive that if you don't take enough milligrams and your blood concentration, your blood serum levels are too low, you're not going to get efficacy because you're just not going to have enough of the medication to make a difference. That's intuitive. But there's evidence, research trials to show that if you give too much medication, too many milligrams, depending on the person's body weight and how they tend to metabolize that medication based on their idiosyncratic physiology, but also what other medications they may be taking. And you have blood serum concentrations at steady state that are too high, that are above a certain maximum value, then you will also lose efficacy. So there appears to be a therapeutic window where you have to be within that window to successfully treat depression. Now, everybody's different. This is not a hard and fast rule, but there's just research to show if it's not working, doing blood serum levels is not the standard of care. But if it's not working in a particular patient, there is justification for drawing a blood level of desipramine to make sure that you're within that window. And if you weren't within that window, then before abandoning the trial, you would want to adjust the dosage, either increasing it or decreasing it. Likely, you would be decreasing it because you're going to start with a low dose and then you're going to titrate it, increasing the dose slowly as the patient tolerates it until you get to efficacy. But if you keep titrating and keep titrating and keep titrating, you get to 300 and the patient still hasn't responded, but is tolerating it pretty well, then you do a serum drug level before you abandon desipramine, because if you're above that therapeutic window, then you would actually want to reduce the dosage, try to get back to somewhere between 75 and 150, say, and make sure that you've given it 6 to 12 weeks, because there is a delayed effect when it comes to the antidepressant efficacy. Again, I would not use desipramine or nortriptyline to treat anxiety states. It could actually make anxiety worse.
Because norepinephrine,
it's adrenaline, it's going to activate the sympathetic nervous system, the fight or flight or freeze system, and that's not good for panic attacks. That just can make things a whole lot worse. It can also make irritability worse.
side effects. Well, first of all, the nonspecifics, nausea, any medication can cause nausea, headaches, diarrhea, dizziness, fatigue. Those are nonspecific side effects. A big one, though, is sedation.
And we think this is mediated by these medications' antihistaminergic effects. So they're essentially antihistamines. And so they block the H1 type of histamine receptor, the type that's involved in seasonal allergies, not the type that's involved in your stomach acid. We're talking about blocking the H1 receptors. They are found in the central nervous system, and they result in sedation, which can be very significant. Mirtazapine is a tetracyclic, a little bit more modern antidepressant that's used a lot, and it too creates sedation through its antihistamine effect. So you want to dose these medications at bedtime. You want to try to use them as sleep agents as well as antidepressants. And if you do have to dose them throughout the day, you want the larger dose to be at bedtime. Weight gain is another real problem with these agents. They increase the appetite. They don't change the metabolism. They increase the appetite, especially for carbohydrates. For some reason, you're not going to crave broccoli, but the pastas and the sugary sweet foods, you're really going to want those more, and you're going to gain weight from that, and it could cause metabolic syndrome, type 2 diabetes, hypercholesterolemia, elevated cholesterol, as well as a bad ratio of the quote-unquote good cholesterol to the bad cholesterol, dyslipidemia. You really do have to weigh patients at baseline and monitor them very carefully. That's a huge drawback and a deal breaker for a lot of patients. They also, all of them, to some extent or another, block muscarinic acetylcholine receptors. So they're anticholinergic, and you get all of the side effects that go with that, from dry mouth to constipation. To urinary retention, to blurred vision because it impairs accommodation. So you get blurred near vision. The pupils can't accommodate. All of these medications can cause sexual dysfunction, mostly anorgasmia and a lowered libido because of the serotonergic actions, but you can also get erectile dysfunction. That could be a consequence of a low libido, but it could also be a direct effect of norepinephrine, which inhibits the parasympathetic nervous system and interferes with the erection. In a lot of men, particularly men that are middle-aged, they might have other risk factors like cardiovascular disease, chronic hypertension, etc. Orthostasis, orthostatic hypotension, is a loss of blood pressure, a drop in blood pressure in the cranium upon standing. Ortho means upright, erect, stasis, to stand. And so when you get up, especially if you've been lying down or even sitting down, and you come to a standing position, the blood pools due to gravity, and your vasculature is supposed to compensate by constricting to maintain pressure, but you get interference with that system with these medications, and that can lead to dizziness and even fainting and falling. We do see severe hypotension in overdose. You want to get a baseline EKG in your patients that are older than 50, because these agents can also cause QTC prolongation. QTC stands for the corrected QT interval, and that refers to the electrocardiogram, the QRST complex, which measures in milliseconds the length of a heartbeat. So in patients who already have varying degrees of heart block, you want to avoid using tricyclic agents, or in patients that already have arrhythmias, because prolongation of the QTC could lead to fatal arrhythmia, a torsade de points, which looks like this and looks like this. Again, these medications are fatal in overdose. You see seizures, arrhythmias, fatal arrhythmias, coma, and death. Definitely not a good choice for patients that are chronically suicidal or patients who are prone to overdose. Other side effects include sweating, increased sweating, because you have the increased norepinephrine, and so upon exertion. But also you could, in theory, have hot flashes as well, temperature dysregulation. That's due to increased serotonin. I have another video, it's an instant replay on sweating, on drug-induced sweating, so you can check that out for more information. Heartburn has been reported, a weird taste in the mouth, that can happen. These are not as common. Akathisia, which is a motor restlessness, a fidgetiness, a need to move and feeling very uncomfortable if you can't move. In the extreme, it takes the form of pacing, but probably more commonly you would see fidgeting, squirming, inability to stay seated, maybe a bouncing knee or a tapping toe. That's called akathisia, and it's due to increased serotonin, which is antagonizing dopamine in certain regions of the brain. You can also see rarely the induction of mania in those individuals who are susceptible to it. So patients with bipolar spectrum illness, you're not going to see mania in patients that aren't prone to manic episodes. Even in overdose, you're not going to see mania unless you have a person who's bipolar. And similarly, patients that are vulnerable to psychosis would be at increased risk, theoretically, but this is rare. Controversial side effect would be suicidal ideations. Any antidepressant, in theory, especially in young, impulsive people, could, in theory, increase suicidal ideations and even behaviors. This is controversial. It's not really been proven. I am on the side of there's really very little proof of that, and I certainly don't worry about it in really any of my patients. Definitely not in patients that are older. But I warn all patients about it. I ask all patients about suicidality, whether they've had problems with depression or not. And I do caution them that if they start to have thoughts, weird thoughts, to let me know. In a young, impulsive patient, you really do have to be careful about that. And the other thing to really be careful about when you combine tricyclics with other medications are any medications that would inhibit the metabolism of tricyclics, and that would include medications that inhibit the cytochrome P450 system, specifically 2D6, medications like Prozac and Paxil, Wellbutrin, Cymbalta. You would also want to be careful about combining with other medications that are anticholinergic, because that could lead to hyperthermia, delirium, and even death, as well as paralytic ileus, where you slow down the gastrointestinal tract so much that it actually grinds to a halt, and that could lead to perforation in the worst case scenario, and especially in the elderly, patients who are very vulnerable to the side effects induced by blocking muscarinic acetylcholine receptors. You want to be careful when you combine with tramadol because of the risk of serotonin syndrome, but again, not desipramine. And you want to be careful, but tramadol, which is an opiate analgesic, also lowers the seizure threshold. So you would want to be careful there because you could increase the risk of seizures if you had a dose of desipramine that was too high and you combine that with a high dose of tramadol or any other agent that lowers the seizure threshold. You would want to be careful about combining with medications that prolong the QTc interval on the electrocardiogram, which measures the length of the heartbeat in milliseconds. Medications like Mellaril and Pimozide, Thioridazine and Pimozide, they're first-generation antipsychotic mood stabilizers. They aren't prescribed very much anymore, but Mellaril is famous for you don't want to combine it with any other medication that prolongs the QTc interval, because that could lead to heart block or a fatal arrhythmias such as torsade de pointes, which can lead to death. And there are also certain antibiotics and antiarrhythmic agents that, and then of course beta blockers, which are used for a variety of conditions, hypertension, also to prevent migraine headaches, etc. Those medications slow down the heart rate and can cause bradycardia, and you definitely don't want that. You definitely don't want to prolong the QTc interval further in patients that already have bradycardia, whether it's drug-induced or part of their own cardiac morbidity. Thanks for listening. If you want an overview of all of the tricyclic agents, please check out that video.